Hi, this is Dr. Nick. I'm the incrementalist here with incremental insights for a better business and a better health.
And I'm Fred Goldstein with Accountable Health, here helping employers and other companies open up and operate during the COVID pandemic. So this past week we did an interesting webinar with St. Edward's University where we discussed the reopening of the university. Nick, you did a great job on that as always. One of the things we were watching as we answered questions, and there were quite a few of them, were these questions related to testing. There's a lot of confusion around types of tests, when, etc. Could you address some of those areas?
Absolutely. So first off, there are lots of different tests, and there's also some confusion because I think there's people use terminology that is shared or sometimes not quite accurate, and it can be a little bit confusing. First of all, let's break them down into two basic categories. The diagnostic test. So do I have the disease or the virus, more importantly? And this is one of the key things here. These diagnostic tests look to find evidence of the virus from samples. And the samples are taken from the brain tickler, as people know it, the one that goes all the way back into the brain through the nose. There's a shorter version of that nasopharyngeal swab. And then there's also spit at this point. They're all collecting where we expect the virus to be, those virus particles, and then looking for aspects of it. And these molecular tests look for the virus, and in the case of the coronavirus RNA, it uses some amplification techniques to take those viral fragments and says, do I see them? And if we see them, then that person is shedding virus, so they have virus particles. Now, one of the things that is confusing in some instances, certainly we've seen this with people that have positive tests for many weeks and they're asymptomatic, and if they had symptoms, they've recovered. We think that people shed elements of the virus. These tests are pretty sensitive and they're picking up the fact that those viral fragments are there, but the individual is not infective, which is one of the reasons why we don't recommend, or it's not recommended, to test somebody out of quarantine or isolation because that doesn't work in some particular instances. We use a symptom-based strategy. Now, the other thing that's arising is something called antigen tests, and they look for the surface so that everybody's seen the picture. I think everybody can point to a coronavirus at this point, those little spikes, and that's where the name corona came from. It looks like the corona. And those protein coats or pieces of that are sought out in what's called an antigen test. It can be a little bit less specific, so it doesn't always pick up, but that's one of the targets that we have for screening activity. But it is also an infective. So if you see those targets, then you have the virus, or we think you have the virus. There can be some confusion because those little spiky bits could be shared with other viruses. So we have to work that out. So those are the diagnostic tests. The antibody test, that's the test that says, have I had the disease? Let's just put that to bed for the time being. If you have that, it really doesn't tell us anything because we don't know if you get any levels, what they mean. Does it give you any aspect of immunity to the disease? We don't know what levels would confer that. And so essentially, that test is a research-based only test. It doesn't really sort of guide any activity. So hopefully that clears up some of that. I'm trying to think that there were other terms that we use that maybe try and clear up rapid. That's just a function of how quickly you get them back. There's also a move to try and make them non-laboratory. That's really a cost issue and also a speed to get the response so that you can do it in the facility. And we're still working towards that. There are a few instances of that, but that's much harder to do. Right now, that's where we are with the diagnostic tests. But now that we've cleared up the tests.
One quick question.
Yeah.
Abbott's got their new test. What is that? And people are talking about that pretty excited. And why is that?
This is the Abbott. So that's still a molecular test. It's still an RT-PCR. It's has, based on the evidence that we've seen, relatively accurate. So it's got good sensitivity and specificity, and it's something that can be done on a machine that exists that we use for other things. And it uses, for want of another word, a cartridge. So you get the sample, put it into the cartridge, put it in the machine, and you get a read pretty quickly. Still requires a laboratory setup. So it's not a sort of self-administered, requires physician. And all of these tests right now require a physician order or a clinician order to be able to have them. Some states have found ways to get around that, but for the most part, that's what you need. But now that we've cleared that up, or at least hopefully that's cleared it up, how do we apply all of this in the context of an opening for a college, for a business? What are we doing with that, Fred?
Well, it's been interesting. We've both been working on this with a number of universities and talking about it with other businesses. It really is something that we're seeing. The approach by the CDC is you should only be testing people who are symptomatic at this point, and they're not recommending these broader range tests. But what we're seeing universities do, and what we've seen in some of the ones we work with, is this concept of pre-testing everybody before they come back. So that included students, faculty, staff, and even subcontractors. Think about those individuals that are on your campus. And the reason that you're seeing people advocate this is this concept of shrinking the funnel. In other words, identifying people who have disease right before they're going to come back and ask them to quarantine, to isolate themselves for the next 10 or 14 days and not show up at the dorm or at their apartment complex or wherever, and you've automatically at that point reduced some level of risk. What we're also seeing on these early tests is, and a number of universities have been reporting their results that have done this, is very low rates of infection in those students. I think typically, Nick, if I'm correct, we're seeing like less than 1% at most universities. What then happens is they come back to campus, suddenly they're greeting old friends, meeting new friends, getting into larger groups, and you suddenly see these spikes at the universities. And the question gets to that, which is about contact tracing, et cetera. But from a testing perspective, most of the universities we're seeing that seem to be a little bit more effective have got some sort of an ongoing strategy, whether they're testing on a sample on a regular basis or testing every 2 days, twice a week, as some universities are doing. And that appears to be a good way to also create another layer of mitigation to reduce your risk. So it's been interesting to watch. Some universities obviously have not done testing. You're seeing some places go very large, very fast, and then choose to shut down. But others seem to be riding this and trying to figure out on an active basis how to keep the risk down and keep it under control so they can keep operating and have their students at the campuses.
So if I was to take one message out of those two sort of explanations, it's this stuff's really complicated and you need help navigating this complex area. And if there's anything that I think we have been very good at is teasing out science and fact from fiction to be able to apply it in each of those circumstances. So if you need help, you should reach out and ask us.
Absolutely. Again, another fantastic week with you, Nick. Looking forward to the next one. This is Fred Goldstein with Accountable Health. Thanks so much for listening.
And I'm Dr. Nick. I'm the incrementalist here with incremental insights for a better business and a better health.